Great pleasure to be back this morning, and Dr. Narul regrets that he's not able to be here today. So I will give a short overview of his topic and then launch into my topic also. And I will not go into great detail because Dr. DeMaria will be giving more discussion of intracoronary imaging. But if I was designing strategies for imaging, and if I was Dr. Narula, I would suggest that the core imaging can give us very important insights into acute coronary syndromes, intravascular imaging in particular, ultrasound, IVUS radiofrequency analysis, or tissue characterization, optical coherence tomography, near-infrared spectroscopy, elastography, or coronary angioscopy. And Dr. DeMaria will be talking about these important topics in detail regarding IVUS, which clearly can give us important issues regarding plaque burden, in some cases plaque characterization, but the difficulty with IVUS are some important limitations. It does not have the resolution to measure the thickness of the fibrous cap, which we talked about yesterday being so important in identifying vulnerable plaques. It identifies the ruptured plaque quite well, but does not readily identify the vulnerable plaque, and inability to determine elements of plaque composition. However, using radiofrequency analysis with IVUS, one gets more information regarding the characteristics of the plaque itself, regarding fibrous tissue, fibrofatty tissue, the necrotic core, and dense calcification. As discussed yesterday, the validation of this has been quite well worked out with IVUS, less so with CT, but CT is rapidly evolving for this purpose also. And so using virtual histology, a pullback along an arterial segment can show the various components of the calcification, the necrotic debris, the fibrous tissue, etc. And as we discussed yesterday, and I'm sure Dr. DeMaria will mention this also, the prospect investigators actually use this tool to predict outcome of patients following an acute event and PCI, realizing that the outcome was predominantly patients who developed chest pain subsequently, not patients who had heart events such as death or myocardial infarction. Limitations of this analysis are the inability to distinguish thrombi from other plaque components, limited spatial resolution because it is ultrasound, and again, therefore, the inability to accurately measure the fibrous cap, and then the reproducibility of these tissue measurements really, I think, needs further validation. Optical coherence tomography does give us that exquisite resolution that's missing with IVUS, does allow us to look in a normal artery of the three layers, intima, media, adventitia, very exquisitely measures cap thickness. So here we have a large necrotic core, very thin fibrous cap. Dr. Vermani's pathologic analyses have told us that a cap thickness less than 65 millimeters is vulnerable, usually represents inflammatory cells that are thinning the cap. And so here's a patient studied by Dr. Mueller at 2 points in time. Baseline showing a thin fibrous cap, lots of necrotic debris. 6 months later, rupture of the plaque, and rupture, ulceration of the thin fibrous cap. More necrotic debris on intravascular ultrasound. But here we see how the cap itself has ruptured. It's possible to identify other characteristics of the plaque itself. McNeil and co-workers and others have demonstrated that it is possible to identify when there is inflammation, looking at macrophage distribution in coronary plaques using optical coherence tomography. And Tierney and co-workers have moved the field forward by giving us three-dimensional measurements. So a pullback here with OCT giving us a three-dimensional display, including a previously inserted stent. So OCT does give us important new information, not resolvable with IVUS. The difficulty here is it's using light. Therefore, there's limited tissue penetration of light. One needs to remove the blood in some way because the blood will attenuate the image. that requires either occlusion balloons, saline flushes, or other measures to transiently visualize a plaque, because one cannot do this over a long period of time since we're disrupting the blood flow. The strengths are the high resolution for fibrous cap thickness, plaque composition can be assessed, excellent identification of thrombi and plaque ruptures, missing sometimes with IVUS, identification of plaque erosion, where you do not have a plaque rupture per se, and this is the unique property of OCT, not visualized with other methods, and identification and quantification of macrophage content. Moving on, one other important area of current work is infrared spectroscopy, near-infrared spectroscopy, allowing one to identify inflammatory tissue. And again, I suspect Dr. DeMaria will go into greater detail with this. Sue and co-workers have shown in a pullback model, again, identifying where there is an active area or areas of inflammation across the arterial tree from here to here. So the insights from vascular imaging, Dr. DeMaria will go into greater detail, and here he is, would include these tools. This is the toolbox that he'll be discussing: intravascular ultrasound, IVUS with virtual histology, optical coherence tomography, near-infrared spectroscopy, intravascular elastography, and coronary angioscopy. So what would be the goals of imaging in acute coronary syndromes? Can we identify inflamed plaques, thinning of the fibrous cap, lipid-laden plaques, necrotic core, plaque rupture, plaque erosion, and thrombosis? And again, he will be going into greater detail in these tools in the invasive setting. And I'm going to shift now to the presentation that I was asked to give, which is more of how we use non-invasive imaging and whether this is also helpful in patients who may have had events or in patients who are trying to predict events. And so that gets into the issue of are we getting added value or added cost? So because we're talking about the Lancet with Dr. Spencer, I had the opportunity to write an editorial for Lancet where I got into some of these issues that we'll talk about for the next few minutes. What's passed as prologue. I called it passed as prologue because Professor Mazari and I were talking yesterday with Professor Yacoub about some of the leaders in the field when we were training, or at least when they were training, such as Paul Wood. And in Paul Wood's first textbook of heart circulation, which I know they have on their bookshelf and I have on my bookshelf, there's great insights one can obtain from the wisdom of a preeminent leader of the field in 1951. Professor Paul Wood. And he said the rapid advances in cardiology during the first half of the 20th century may be fairly ascribed to the introduction of new technology 50 or 60 years ago. And of course the technology he was dealing with was essentially this form of imaging, a chest x-ray. That was his tool, one of his only tools besides this and the EKG. So imagine what he would do if he were alive in the second half of the 20th century. He died prematurely from an acute coronary syndrome, actually, in 1962. So he was not around to visualize what we can now do with technology, whether it's MRI or CT. He also was not around because he contributed to the peak of the coronary epidemic. He was an event in 1962, so he was not able to witness not only the technological advances, but also all of the advances we discussed yesterday in terms of reduction in coronary deaths in the developed countries of the world. Dr. Spencer showed a wonderful figure of all of the Western countries declining coronary events. And so in the US, Ford and co-workers pointed out dramatic reductions in the age-adjusted coronary death rate for both men and women between 1980 and the year 2000. Over a 20-year period, striking reductions in the annualized age-adjusted coronary event rate. They ascribe most of this to changes in risk factors, as we also discussed yesterday, 44%, and secondary prevention, another 11%. So over 50% of the reduction was ascribed to changes in risk factors, not treatment of ACS, that's only 10%. Treatment of heart failure, 9%. Revascularization, 5%. Other therapies, 12%. So where is imaging here? Did imaging contribute anything to this? One could perhaps argue that imaging allowed us to identify the patients, in some cases for prevention, identify the patients with heart failure by measuring the ejection fraction who might benefit from an ACE inhibitor or beta blocker. But the difficulty here is that it's virtually impossible to tie the imaging test itself to the improved outcomes. It's not the image that leads to the better outcome, it's how we interpret the image and how that translates into a treatment algorithm of some sort. And that's the problem, because imaging is also very costly. And as John Iglehart writes very frequently in the New England Journal of Medicine about our healthcare policy issues, imaging has also increased more rapidly than any other component of medical care. It's very used very commonly. I cannot imagine managing virtually all of my patients without one imaging test at one point in time, in some cases serial imaging tests. And yet it's impossible to tie the imaging test to improve cardiovascular outcomes. So what do we do in the current era where we have non-invasive tests, echo, nuclear, cardiology, MRI, cardiac CT? Echo gives us great usefulness not only for structural heart disease but also for coronary disease, because we can do stress imaging, portable, available, inexpensive, stress protocols established and straightforward. We have advances in myocardial contrast, tissue Doppler imaging, 3D imaging, things that you do every day in your own practice. Nuclear cardiology, also readily available, inexpensive. Stress protocols are established and straightforward. A very extensive database regarding the prognostic value of these tests as well as their diagnostic value, allowing us to do risk stratification. But I'll come back again that even though we can assess prognosis and risk stratification, we cannot demonstrate that this is actually leading to improved patient outcomes. Now, there are some data one could discuss that perhaps does suggest that imaging does lead to outcome differences. This is a study called the END study by Leslie Shaw and co-workers. It's not a prospective randomized trial, but it's roughly 6 centers in the United States that pooled their data regarding the outcomes of patients who came in with chest pain, whether they're evaluated initially in the cath lab, going straight to the cath lab to get the angiographic information and or PCI, and in gray, patients who first have a stress test. They subdivided the patients according to their clinical risk based upon their initial age and risk factors, low, intermediate, or high. And they found no difference in outcome, no difference in death or myocardial infarction over the course of the follow-up period. You see roughly more than 5,000 patients in each study. So no difference in outcome. The non-invasive test did not lead to a better clinical outcome. However, when they looked at the cost was less in each of the 3 clinical strata if patients first had the non-invasive test, identifying patients perhaps who did not need the angiogram. And so the implications for health policy might be that one could achieve the same clinical outcome at less cost. And so despite the fact that the imaging tests do cost something, it may lead to a better result from a cost outcome analysis. On the other hand, we also have data that this is not done outside of a study such as this in clinical practice. Patel has looked at the data in the American College of Cardiology data registry, very healthy data registry here, a repository of nearly 400,000 patients in 663 hospitals undergoing angiography. 84% did have a non-invasive test beforehand. But they found that only 38% had obstructive CAD, 39% had no CAD at all, less than 20% stenosis. And here are the findings relative to the results of the non-invasive test. A positive test, a negative test, an equivocal test, or no test at all. And there was no difference regarding whether patients had obstructive CAD, whether they had low clinical risk, intermediate clinical risk, or high clinical risk. And so the non-invasive test in practice in 400,000 patients was no better than doing no test at all in determining who had obstructive CAD. That's real-world data. And yet, we also know that one can obtain very important functional information in the cath lab. So why do a non-invasive test to assess coronary flow reserve if we can do that in the cath lab, as we have seen here from the FAME-1 and FAME-2 studies that allow us to directly determine in the cath lab setting which patients have a obstructive lesion which is limiting coronary blood flow. So that's a challenge for non-invasive imaging if we have inaccurate results. And the patients in the cath labs will then have a better, more accurate way of identifying coronary flow reserve. So does MRI or CT give us additional information, more costly imaging, but perhaps imaging that may give us better results? Of course, our patients want this. Our patients read headlines such as this from Time magazine, how to stop a heart attack before it happens. One should have a CT scan because amazing detailed new heart scans help doctors spot trouble without surgery. I think that means without angiography. How technology could save your life. So our patients see this. Our trainees see this. This is a journal that's picked up by our cardiology fellows many times. And so a fellow in training wrote he was looking for advanced training in cardiovascular imaging because all of our fellows want to have their skill set to include CT and MRI. And MRI clearly gives us very important opportunities. I have videos here that unfortunately can't play, but I think you can get the picture here that we get anatomy, function and wall motion, myocardial scar because of the contrast enhancement, myocardial perfusion, exquisite angiography, whereas coronary MRA and plaque characterization, as we discussed yesterday, are obtainable in some patients, but not in all patients routinely. So if we want to image plaque, we can do that routinely today by not using CMR, but by using CT, which also allows us to look at all of these properties as well. Function and wall motion, scar and viability, because the iodinated contrast is also retained in non-viable tissue, as it is with MRI. And of course, we now are in the era where we can non-invasively get the coronary CT angiogram and the plaque, whether the plaque is soft plaque or calcified plaque. We discussed yesterday how coronary calcification may be an important way of risk stratifying patients. Here are two individuals. They're 52 years old. They're both men. One has no calcification. One has extensive calcification. Which patient is a candidate for aspirin, a statin with aggressive lipid lowering, or an ACE inhibitor? Well, the answer here has nothing to do with the images, because maybe both patients are candidates for ACE inhibitors and beta blockers and statins and aspirin, depending upon their other factors, their symptoms, high cholesterol, family history, etc. But the patient on the right already has extensive atherosclerosis. There is information here. This is not a risk factor. This is the disease. This patient has the disease already. And so in my practice, because many patients in Chicago come to me having had this test already, I would say, well, this patient already has evidence of coronary disease. I would shift from primary prevention in this patient to secondary prevention. Very aggressive lipid lowering, perhaps adding an ACE inhibitor as well as a statin and an aspirin. So this patient, in my practice, might be treated more aggressively than the patient on the left because I have this extra information. And there are data suggesting that that may be appropriate because CT does allow us to identify higher risk individuals using the calcium score, as was discussed yesterday as well. So here's data from Leslie Shaw, 10,000 plus patients undergoing a CT calcium score. And one sees that the calcium score is predictive across 4 to 5 years of survival. This is mortality data, but these are unadjusted data. One has to now adjust these patients for their underlying risk factor burden, and when they did that, you see how the curves tighten up dramatically. So the CT scan gives us some information in addition to the risk factors, but not as much as we saw in the unadjusted data. But there's still important data here. If we have over a calcium score over 1,000, one sees that their survival is significantly reduced compared to patients who have less severe calcium burden. But there's an issue with this analysis that comes up all the time. How many patients are we talking about? So here's a 5-year mortality that we see here. No calcium, calcium that's mild versus calcium that's severe. 5% per year mortality rate when they have greater than 1,000 for the calcium score. However, how many patients are there in each group? There's very few patients with a very high calcium score. There's many more patients who have no calcium or only a small degree of calcification. So when you do the very simple mathematics, more patients are dying in the low-risk group than are dying in the high-risk group. So we can identify a relatively higher risk group, but the absolute numbers of patients who die are patients in the low-risk group. This is true in many other areas of cardiology, including in cardiac imaging. We see this also in the MESA trial. We'll come back to this trial because it's a very important trial in the United States of asymptomatic individuals, looking at ways of identifying risk over the course of time, multi-ethnic in the US. So MESA is multi-ethnic study of atherosclerosis. So we're looking at the Caucasians, African Americans, Latinos, and Orientals. And they also showed that the calcium score was the most important single predictor of events in these patients. So here's major coronary events, death or myocardial infarction over the course of 5 years. We see again that the higher calcium score, greater than 300, identifies a higher risk group. But if we now look again at the event rates, when we have greater than 300 calcium score, 3.8% per year, death or myocardial infarction, only 0.6% when we're dealing with a low calcium score or zero calcium, but there are many more patients who have the low calcium score. Number of events is actually the same in both, whether it's a low calcium score or high calcium score. So we've been able to risk stratify the group, but from a issue of who is going to die, we have the same number of events in both groups. So where this comes in, as was also discussed yesterday, maybe is not applying an imaging test to all patients, but let's take the group where we have need for more information. Here's the Framingham risk score in a large number of patients studied by Arad and co-workers, looking at coronary events over 10 years. Low Framingham risk, high Framingham risk, intermediate Framingham risk. They then looked at what would happen if a calcium scan was done. And they looked at 3 groups of individuals based upon their calcium score in tertiles: low calcium, intermediate calcium, high calcium. In all 3 groups, one sees that the calcium score was predictive of higher event rates with higher levels of intracoronary calcium. But in the low risk group, even though the risk was higher with high calcium, the overall risk remains low. In the high Framingham group, although there's stratification, risk remains high even if you have no calcium. But this intermediate group is important because in this intermediate group, one gets a 6-fold increase in risk as we go from low calcium to high calcium. So it's this intermediate risk group where many times it's uncertain how aggressively to provide risk factor management, where we get important extra information. And this has led to the documents that were discussed yesterday regarding the application of CT scanning, both in the US and Europe, and the 2010 ACC-AHA recommendations for cardiovascular risk assessment with CT scan say that it's reasonable to assess coronary artery calcification in asymptomatic patients in that intermediate risk group, but only if it's going to change your management. This is based on the possible reclassification of such patients to a higher risk status based on a high calcium score, and therefore patient management might be modified. If the patient is already receiving aspirin and very high dose statin therapy, it's not clear this is going to change our management. But where this does come in is that we do have data showing that the coronary calcium score can add important reclassification to our risk assessment. This is a paper from the MESA trial by Polanski and Philip Greenland and others. They looked at the outcome in MESA that we had been talking about previously, first looking at the Framingham risk score. and then adding in coronary calcification. So very similar to the study by ARID that we talked about a few minutes ago. Polanski and co-workers in the MESA trial looked at the number of patients who had coronary events in MESA, death or myocardial infarction, first applying the Framingham risk score. Low Framingham risk, high Framingham risk, intermediate Framingham risk. So the Framingham risk score works quite well. We identify the low risk group, intermediate risk group, high risk group. So it's a verification of Framingham. But here, look, we did again have this issue of numbers. There are so many more patients with low and intermediate scores compared to high risk Framingham scores that when we don't look at the percent with events, but the number of patients with events, the curves look more like this. So there are more patients with low risk scores and intermediate risk scores who have coronary events compared to the patients with high risk scores. Same, very similar analysis that we saw previously. However, now they apply the coronary calcification information, and they found that they could really, importantly, reclassify the individuals so that there were more patients identified in the lower risk groups who had lower events, more patients now identified as being high risk, and these curves shift now more to the right. And the mathematics was important because the net reclassification was 0.25. This is very high, a very high degree of reclassification of patients. 23% with events were moved to the high risk group, 13% without events moved to low risk. So it does add important risk stratification. Having done that, my question would be if we now can identify more accurately the risk, does it actually change the outcome? What we need is a study showing that we can do such an analysis, treat patients differently, and have them have a better outcome. So coronary calcification score adds to risk assessment, reclassifies patient at risk, but does it change patient behavior? Does it lead to improved outcomes? And here we have no data that there's actually a better outcome, having gone through all of this. In fact, there is a randomized trial by O'Malley and co-workers looking at CT scanning, providing information to the patients, telling which patients should be receiving aspirin and statins, and improving their risk factor profile. Over the course of 1 year, the calcium screening, when provided to the patient, did not motivate patients to make evidence-based changes in risk factors, was not associated with improved risk profile at 1 year. And so the imaging did not lead to a better patient outcome in terms of patient adherence to the recommendations for changes in lifestyle and medication therapy. So we need more work. Moving beyond the CT calcium, of course, maybe there's more information one can get from CT angiography, because we do have the attainment of the holy grail now of the non-invasive coronary angiogram, not only to look at the lumen, but also to look at the vessel wall, as was discussed yesterday, because we can visualize with CT not only the calcified plaque, but also the soft plaque. And the soft plaque may be more important, because that's where we have the lipid burden. A number of investigators have evaluated this. Min and co-workers looked at the prognostic value of multi-detector coronary CT for predicting all-cause mortality in their preliminary work in 2007, Journal of the American College of Cardiology. They could visualize the non-calcified plaques, grade them according to moderate and severity, mixed plaques where there is both calcium and non-calcified plaque, grade those, mild, moderate, severe, calcified plaques, mild, moderate, severe, coming up with a risk algorithm including the non-calcified as well as calcified plaques. And they found that this was quite helpful in identifying patients' survival. Here are the patients who have none or mild plaque, or only one vessel disease. Here are patients who have moderate or severe calcification. 1,100 patients. Well, importantly, as we discussed previously with CT, there are more patients in this group than in this group. And so when you actually look at the number of deaths, there are 14 deaths here, 15 deaths here. And so we see the same analysis that we saw with CT. The larger number of patients here, even though at lower risk, leads to the mathematics that the outcome is roughly equivalent in terms of total deaths. Well, they carried this forward to a larger study called the CONFIRM Registry, very important analysis in 2011, a multi-center analysis across many countries involving 24,000 patients, applying the same analysis, identifying normal and non-obstructive plaques versus 1 vessel, 2 vessel, or 3 vessel burden. Well, we see, unfortunately, I hate to be repetitive, but the same finding.
Your time is up.
Normal versus 3 vessel disease. Death rate very low versus much higher, but there's 10,000 patients with normal coronary arteries and only 1,000 patients with 3 vessel disease. There are more deaths in the group with the normal arteries. So have we actually led to a better ability to identify which patients will die or not? Importantly, we have to worry about CT because of the medical radiation, which has led to serious concerns in the United States about the added burden of medical imaging from all forms of imaging, not just cardiac imaging, but elements of danger in the editorial by Michael Lauer at the National Heart, Lung, and Blood Institute. At the same time, we have costly imaging. Heart therapy strains efforts to limit costs. Diagnostic imaging, as pointed out before, has increased more rapidly than any other component of medical care. These are data from our Medicare database. These are all patients in the US over the age of 65 who receive our federal insurance. You can see everything we do has increased in terms of tests, procedures, other major procedures, evaluation and management. The mean increase is shown here for all physician services, but in yellow is imaging. So imaging has increased more steeply than any other component of medical care. And in the cardiology realm, we see that most of this is because of cardiologists doing tests in the cardiology office. This is looking at the procedures in millions of Medicare patients over 65 undergoing cardiac testing, non-cardiologists in the hospital, radiologists, non-cardiologists in the office, but here are the cardiologists, not in the hospital, but in the outpatient setting, because cardiologists get reimbursed for doing tests, and they could do tests in the office and get reimbursed for that. That led to steep increases in the utilization of these procedures. And that's led to major cutbacks in what physicians now receive in terms of reimbursement. And most cardiologists in the United States now are no longer in private practice because of this. They now work for the hospitals. So we have unresolved issues regarding how imaging would be applied. Who should be studied? Who should interpret the study? Who will pay for the study? Who will train whom? Do cardiologists train radiologists, and do radiologists train cardiologists? In my university, we actually do that, and we do it quite well, but most places, the radiologists and cardiologists do not work together. How will this affect our guidelines, and how will quality be determined and maintained? So we do have many issues, and they need not be unresolvable. They could be resolved by a different form of research, looking at performance measurement, appropriate use criteria, training and multimodality imaging, comparative effectiveness research. Which test in which setting, perhaps in some cases no test might be the best test at all. I participated with Dr. Douglas and others in a workshop at the NHLBI, and we said, well, in the setting of acute coronary syndrome, what might we do in a comparative effectiveness research realm? We would look at whether CTA in the emergency room is effective and cost-effective and safe. We could have inclusion criteria of a patient who has a negative EKG and negative biomarkers. We'd then take this patient group who has equivocal clinical findings, randomize them to a biomarker with or without exercise testing, a standard strategy, versus a biomarker with a non-invasive coronary CTA. We then take that information, allow the patients to have standard processes of care, and see what their outcome is at 30 days, 180 days, survival, procedures, revisits to the emergency room, healthcare costs. Well, this algorithm has now been tested in 3 trials. There's a CT-STAT trial, the ACRIN trial, and the RAMACAT-2 trial. All 3 of these studies in patients with chest pain and equivocal EKGs, possible acute coronary syndromes, came up with the same conclusion, that the CTA definitely established the presence or absence of significant CAD, Time to diagnosis decreased due to more rapid facilitation and testing. And the cost to diagnosis was decreased, primarily due to expedited time to diagnosis, reduced length of stay. So this is causing some impact in policy in the United States regarding how we might use imaging in the acute care setting. And of course, I think more work needs to be done to see exactly how this will play out. So to summarize, CV imaging has become a cornerstone in the diagnosis and management of virtually all patients with CAD. It's transformed and will continue to transform care for patients with CAD. Imaging techniques deliver non-invasive angiography, plaque characterization, delineation of the arterial wall in exquisite detail. But these revolutionary modalities create unique opportunities to improve diagnosis and clinical management strategies, along with the challenges in patient selection, clinical training, integration with established imaging methods, resource utilization, and cost effectiveness. And so I think to summarize, one needs to integrate this somehow in our clinical management. We have very exquisite high-tech tools with the hand on the mouse, but the other hand should be on the stethoscope, where we can integrate the technical information with our clinical information, so that we become not robots and not imagers only, but we remain physicians, because there's evidence that we are in danger of losing our clinical heritage, pinning too much faith in figures thrown up by machines. Medicine must suffer if this tendency is not checked. That's not my quote, by the way. That's a quote from Dr. Paul Wood, who made the same quote back in 1951. And so I come back to where we came before, that past is prologue, and we learn from the masters who taught us decades ago about the importance of integrating technology into clinical management strategies. Thank you very much for your attention.
And, let me start with a question regarding the use of imaging in the emergency room. The three trials that you alluded to, aren't you a little bit worried about the excluded patients?
Yeah, so I didn't have time to go into the nuts and bolts of those trials. And there are some limitations because patients were excluded. In fact, if you look at some of these trials, especially the intermediate one, for the Akron trial, patients who were excluded and had no test at all, not even a stress test, had the same clinical outcome in terms of death, myocardial infarction. And so as far as the what the patients care about, life and death and hospitalization, over the course of time, there was no difference at all. In addition to the fact that some patients, again, as part of a trial, may not have been included. So the analysis boils down to whether this cost-effectiveness analysis, really is important enough to drive policy. My concern is that the overutilization of the imaging may actually increase costs, because we have, in many settings, it's easy to order a test in a patient, whereas sometimes the most important test we do is to talk with the patient, get a feeling for the symptoms. Does it sound like it could be coronary disease or not? And then use clinical judgment as to who should have the test. So again, we need to integrate the technical possibilities of imaging with good, sound clinical judgment. And my interpretation of some of these three trials is that the patients did fine, many times with nothing being done except sending them home, because the event rate was quite low. They were very relatively low-risk individuals. And whether imaging actually led to a better outcome is unclear. And certainly, they did not have a worse mortality. The imaging has helped make a diagnosis more quickly. So a hospital administrator might be interested in doing that. But at the same time, we may be overutilizing imaging.
Let me try to ask you another question. I mean, in the beginning of the 80s, we tried to get into nuclear cardiology, mainly because we wanted to identify the ischemia rather than looking at the anatomy alone. And I think that getting back into non-invasive imaging modalities that look at the anatomical lesion could be a concern.
Yeah, oh, absolutely.
Particularly
Yeah.
that we are driving ourselves into more
Yeah.
revascularization. When
Exactly.
So I don't want your message to be
No. So thanks for these are important questions. Again, I took out, since this is a seminar on acute coronary syndromes, I didn't discuss the application in the patients with more chronic disease. The same workshop that I talked about that led to the algorithm used in those acute coronary syndrome trials also proposed comparative effectiveness research where we would compare a functional test like a nuclear stress test or stress echo versus a CT scan. That is function versus anatomy, which is more important in driving good decisions in our patients. And those actually 2 trials ongoing right now in the United States testing that, the Radiance trial and the Promise trial, both funded by the federal government, looking at which approach, stress testing for functional analysis versus CT for anatomy leads to a better outcome. And that's important. And now it gets back to the same issue that we can perhaps do this in the cath lab to look at the anatomy and the perfusion. And CT now allows us to do both tests in one test because we can also look at the non-invasive measurement of fractional flow reserve with CT, as we saw from a paper at the European Heart meeting last year. So the field is evolving, and I think we do need to ask the question, do we want functional assessment of ischemia versus anatomy? Can we do that in one test? Is that accurate? Is it cost effective? And most of all, does it lead to better patient outcomes? So again, we need more time to determine whether that's going to be the case or not. These are important questions, certainly in my country, and I suspect also in yours.
I have a question related to the value of imaging the ruptured plaque. At least at the present time, we treat it as a systemic disease since it's rupturing everywhere, and the value of localizing it might not be that very helpful, particularly the attempts of sealing the ruptured plaque was not crowned by any success. I have another question related to the ideal method of imaging the plaque erosion. We are accustomed to diagnose it if we find a thrombus burden without an underlying ruptured plaque, so we assume that there is a plaque erosion. Now we are being told that there are new imaging modalities, including the OCT, that can have a good resolving power to diagnose it. So what's the sensitivity?
So the reason I ran over, for those who came in late, is because I gave a little bit of Dr. Narula's talk also. Dr. Narula cannot be with us, so Dr. DeMaria and I have a little bit of extra time to have our discussion. And I actually discussed a little bit of that initially, and I really want to hear Carla's point on this as well. So we can do OCT. I actually showed images from OCT, as well as intravascular ultrasound, just as a quick introduction of what Dr. Narula might have talked about were he here. Yeah, OCT is a very uniquely designed method to look at the plaque with exquisite detail, including the fibrous cap thickness, which is unique with OCT. We can also visualize thrombus much better with OCT than you can with intravascular ultrasound. And Dr. DeMaria will go into, I'm sure, greater detail with this. But I think it's more of a research tool as opposed to one which is going to be used clinically, although perhaps this will evolve in the clinical realm. As you pointed out, do we want to identify the vulnerable plaque in a patient, or is it the vulnerable patient? And maybe imaging the carotid artery may be equally beneficial in identifying patients who have vulnerable plaques in the carotid artery and also in the coronary circulation and elsewhere. And so I think the intravascular imaging in my view of the world is that it's helping us understand the physiology and pathophysiology of what acute unstable plaques do and why they rupture, and also identifying the frequency with which plaque erosion occurs, because plaque erosion can also be visualized with OCT, as you point out, where it cannot be visualized well with intravascular ultrasound.